Hello everyone, welcome back to the series of lectures in neurology. From the past few sessions, we have been discussing a lot about stroke. We've learned about the localization of stroke, we've learned about the management of stroke, and we've discussed in depth about ischemic strokes. So now we will be moving on to the next session, which is your hemorrhagic stroke. So let's begin. So what are the etiologies for a hemorrhagic stroke? Hemorrhage basically means bleeding into the brain parenchyma. Okay, so one of the most common causes for a hemorrhagic stroke is your head trauma. So whenever there is a head trauma, for instance in a road traffic accident, at the site of injury you can have a coup injury, and diametrically opposite to the coup injury, because of the deceleration force, you can have a counter coup injury. So coup and counter coup are the mechanisms for injury in a head trauma. So hemorrhage in a head trauma can happen into the parenchyma, which is an intraparenchymal hemorrhage. You can have lobar hemorrhages, you can have subarachnoid hemorrhages, extradural or epidural hemorrhages, subdural hemorrhages. All these kind of hemorrhages can be there, which can result in a hemorrhagic stroke. Then the second, which is one of the most common causes again, is your hypertensive emergencies. Okay, so hypertensive hemorrhage. Whenever there is severe hypertension, you can have bleeding into the brain, and that is what we call as your hypertensive hemorrhage. Fine. So the most common site for your hypertensive hemorrhage is your putamen. So putamen is your most common site, followed by globus pallidus. Then you can have thalamus, bleeding into the pons, bleeding into the cerebellar hemispheres. So these are the sites for your hypertensive bleeds. Okay. Chronic hypertension may also produce hemorrhage. These are small hemorrhages. These are hemorrhages in the small vessels of the brain. So they are small hemorrhages in those regions. But when you have acute severe hypertension, sudden rise in the blood pressure, you have a chance of larger hemorrhages into the putamen, into the globus pallidus and other areas, as we have discussed. Then, ischemic stroke, does it have a risk of hemorrhage? Yes. Ischemic stroke can undergo hemorrhagic transformation. The word is transformation. So ischemic stroke can undergo hemorrhagic transformation, especially in the subcortical regions and the basal ganglia. Okay, so this happens in up to 6% of the ischemic strokes. So how will it present? It will present with new onset neurological deficit or a sudden drop in the sensorium, right? So this can be because of a hemorrhagic transformation of an ischemic stroke, which is more common in larger strokes, like strokes which involve more than 1/3 territory of the MCA infarct. Or if there are basal ganglia strokes or subcortical strokes, you can have ischemic strokes having a hemorrhagic transformation. Right? So there is bleeding into the infarct, and that is what we call as hemorrhagic transformation. Fine. Then metastasis. Metastatic brain tumors can cause a lobar hemorrhage. Metastasis from where? Lung cancer, melanomas, renal cancer, thyroid, choriocarcinomas, all of these can metastasize to the brains. Most common is your lung cancer. Then coagulopathy of any sorts, right? So in coagulopathy, what happens is, if the patient is on an anticoagulant or patient has a coagulopathy due to some reason, then there is a risk of hematoma expansion. Once he has bled, that is okay, or he has had a trauma and he has bled, that is okay. But there is a risk of that hematoma expanding whenever there is a coagulopathy. Then drugs. The drugs can cause any kind of a lobar or subarachnoid hemorrhage. When you speak about drugs, most often it is your illicit drug abuse. So the two illicit drugs which can cause hypertension and in turn a hemorrhage is a cocaine and amphetamine. So why do these cause hemorrhagic strokes? Because cocaine and amphetamine have sympathomimetic activity and they can cause vasospasm. They can cause vasospasm. Cocaine and amphetamine can cause vasospasm, and when these vessels go into a sudden vasospasm or vasoconstriction, there can be bleeding. Okay, so there can be bleeding into the parenchyma. So cocaine and amphetamine, which are illicit drugs, can cause hemorrhagic strokes. Okay, then AV malformations again can cause lobar or intraventricular or subarachnoid hemorrhage. Okay, then aneurysmal bleeds most commonly cause subarachnoid hemorrhage, but this subarachnoid hemorrhage can extend into any of the areas of the brain. You can have an intraparenchymal extension or an intraventricular extension as well. Okay, so aneurysms can be because of any defect in your lamina of your internal elastic lamina, where the internal elastic lamina of your blood vessels get degraded, or it can be due to an infection. So in infective endocarditis, when the endocarditis metastasizes, or whenever there is an embolism of the vegetation, the infection which is there, the microorganisms which is there is getting carried to the brain, and this in turn can deposit in the vessel walls and cause dilatation of the vessel walls, resulting in a mycotic aneurysm. So mycotic aneurysms are infected aneurysms and non-mycotic aneurysms are not infected. So aneurysmal bleeds can also result in a hemorrhagic stroke. Then we have something called as amyloid angiopathy. Amyloid angiopathy is basically a degenerative disorder, especially found in elderly, where there is amyloid deposition in the vessels. There is amyloid deposition in the vessels, in turn causing inflammation of the vessels. And the kind of hemorrhage that you get in your amyloid angiopathy is your lobar hemorrhage. Okay, so this can be associated with dementia, and it is not common in the age group less than 60 years of age. Okay, so how do you diagnose your amyloid angiopathy? When you do an amyloid specific PET CT, you can have a diagnosis of amyloid angiopathy. Gold standard diagnosis for your amyloid angiopathy is take a pathological sample and you see amyloid deposits within your vessels. So if you do a Congo red stain on that, you can find your apple green birefringence, and this is the most definitive or your gold standard diagnosis for amyloid angiopathy. Then there can be angiomas which result in intraparenchymal hemorrhage, dural AV fistulas which can produce bleeding as well, and dural venous thrombosis. That means that we have sinuses or venous sinuses which are present within the brain. We would have heard in neuroanatomy. So whenever there is an obstruction by a clot to your dural venous sinus, you can in turn have a hemorrhage as well. So how does it result in a hemorrhagic stroke? So most common sites are sagittal sinus, posterior temporal or inferior parietal sinus. Most common is your superior sagittal sinus thrombosis. So what happens is that there can be parasagittal hemorrhage with edema because of occlusion of the vein of Lebbe. Okay, so this produces hemorrhage, right? So occlusion of the vein of Lebbe can have a parasagittal hemorrhage and edema. So the thrombus can be associated with a hemorrhage, and hence they can present with focal neurological deficits. Okay, so the characteristic feature of a dural venous sinus is that they present with headache, they present with focal neurological deficits, because surrounding the clot you can have edema, you can have hemorrhage. So hemorrhage and edema surrounding the clot. Then telangiectasias in the brainstem can also be a rare cause of hemorrhage. So these are about the various etiologies for your hemorrhagic stroke. So please remember head trauma and hypertension being the topmost causes, right? After that you have some of the rare causes, angiopathies, coagulopathies, amyloid angiopathy, then you can have some AV malformations and AV fistulas, dural venous thrombosis. Amongst the drugs, illicit drugs, you remember cocaine and amphetamine. Fine? So this is about the etiologies of your hemorrhagic stroke. Now, let us look at intracerebral hemorrhage. So whenever we speak about intracerebral hemorrhage, the most common etiology is your hypertension. Okay, and the most common site of a hypertensive bleed is a putamen. So the most common site of the hypertensive bleed is the putamen. Okay, so what happens in hypertension? When there is a sudden acute rise in the blood pressure, the vessels can give way because they are not able to take up this high change in the blood pressure, and they can start bleeding into the brain. Okay, so what are the features of hemorrhagic stroke? We had learnt in our basic approach to stroke. Hemorrhagic stroke is maximum at onset. The deficits are maximum at onset, and it usually occurs at the peak of activity. It usually occurs at the peak of activity, right? It usually occurs at the peak of activity, and the deficits are maximum at onset and recovery. The recovery is usually slow. It depends upon which part of the brain is involved. And hemorrhagic strokes are most frequently associated with seizures. They are most frequently associated with seizures. Okay. So this is about the characteristic features of hemorrhagic stroke. So we know that the symptoms are maximal at onset, but in the symptoms can progress over 30 to 90 minutes, right? Sometimes they can progress over 30 to 90 minutes. So whenever you have a bleeding into the brain, there is development of edema very rapidly. And hence you can have symptoms of raised intracranial pressure. Okay, so especially because these is basal ganglia, or you can have bleeds in the brainstem and the cerebellar hemisphere, these are more prone to raised ICP, right? They are more prone to raised ICP because they are enclosed within the smaller cavity. So, raised intracranial pressure symptoms are more common here. So, what are the symptoms of raised intracranial pressure? You present with headache. You have projectile vomiting. You can have projectile vomiting. So, you have headache, you have projectile vomiting. Okay, and as the compression progresses, as the edema increases, compression will progress. There will be compression of the brainstem structures. So, you can have stupor, coma, and you can have brainstem compression as well, right? And there can be compression of the cranial nerves as well, resulting in cranial nerve palsies. And finally, you can have brainstem herniation, which is often fatal. Okay, fine. So, these are the features of your hypertensive bleed, especially a hemorrhage in your putamen or basal ganglia. Now, if there is a pontine hemorrhage, how does a pontine hemorrhage present? So, pontine hemorrhage on clinical examination, there are certain characteristic features. So, on a pontine hemorrhage, you will have pinpoint pupils. The pupils are absolutely pinpoint, and this is seen in your pontine hemorrhage. Apart from that, pontine hemorrhage, depending upon what structures are involved, you can have akinetic mutism as well. Then, cerebellar hemorrhage. If there is a hemorrhage into the cerebellum, depending upon what extent is involved. If the cerebellar lobes are involved, you can have ataxia. If the cerebellar lobes are involved, right lobe or the left lobe is involved, then you can have ataxia. You can have ataxia to that particular site. Okay, so you can have ataxia. Now, always remember that the cerebellum is enclosed within a very, very small space. So, any cerebellar hemorrhage will have rapid increase in the intracranial pressure, causing compression in the medullary structures, right? So, it is very, very important that if you have a posterior circulation or a cerebellar stroke, then the patient has to be operated immediately and they do a posterior craniotomy so that the pressure comes down. So, always remember this. So, these are about the various features of your intracerebral hemorrhage. If there is involvement of the cortex, what are the cortical signs you will have? You can have seizures that we have already discussed. Now, what are the investigations that you want to do if you are suspecting a hemorrhage, right? So, the first investigation of choice is always going to be a CT scan of the brain, because the CT scan of the brain is going to detect your hemorrhage immediately, right? So, the first investigation of choice is going to be a CT scan. So, whenever a patient presents to you with a stroke, I told you in your evaluation of stroke, especially your ischemic stroke also, the first step is to do a CT scan, rule out a hemorrhage. So, a CT scan is going to pick up the hemorrhage very well. Okay, fine. So, when you have to risk stratify a patient and to identify the prognosis, you risk stratify and you identify the prognosis in a patient presenting with intracerebral hemorrhage, you use something called as the ICH score. Okay, so what are the components of the intracerebral hemorrhage score or the ICH score? It includes the age. Age less than 80 is given a score of 0. Age more than 80 is given a score of 1. Then hematoma volume. Hematoma volume less than 30 cc, 0, more than 30 cc, 1. IVH, if there is intraventricular extension, right? So, if the hemorrhage is generally, most of the time it is confined to the cerebral hemispheres. If there is extension into the ventricles, intraventricular hemorrhages, no is score 0, yes is 1. Then infratentorial involvement basically has a poorer prognosis because there is higher chances of raised ICP and brainstem herniation. So, infratentorial, if the intracerebral hemorrhage is present, then it is given a score of 1, if not, score of 0. Then you take the GCS and score it accordingly, and the total score is a score of 6. So, this is basically used in the risk stratification and the prognostication of a patient presenting with intracerebral hemorrhage. So, based on your ICH score, you will know along which direction the patient is going to progress. Fine. Now, let us understand how do you manage a patient with presenting to you with hemorrhagic stroke. So, always understand you take care of your ABC. ABC is your airway, breathing, circulation, right? So, most of the patients, they might present with altered sensorium, they will present with a low GCS. So, they will not be able to protect their airways. Hence, you will have to intubate them and put them on a mechanical ventilator. You put them on a mechanical ventilator. Also ensure that the blood pressure, if it is a hypertensive hemorrhage, the blood pressure will be elevated, it will be astronomically high, it may be about 200, more than 220, more than 240. These kind of blood pressures you will be seeing. So, the blood pressure has to be rapidly reduced. It has to be rapidly reduced. So, when we spoke about the blood pressure management in an ischemic stroke, we said that it has to be reduced slowly because you do not want to cut off the blood supply to the penumbra. You want to salvage the penumbra. But here, because this is a hypertensive bleed, it is a hypertensive emergency, the blood pressure has to be rapidly reduced, and you use IV drugs. You use IV drugs like labetalol, and you bring down the blood pressure rapidly less than 140/80 so that there is no risk of further bleeding. Okay, fine. Then you will have to confirm the diagnosis, urgently shift the patient on a priority basis to a CT room if it is available immediately, or refer the patient to a CT scan. You get the CT scan done and see what type of hemorrhage this is. Okay. Then the main drugs which are used in the management of the blood pressure and management of your hemorrhage is your non-vasodilating drugs, because you do not want to compromise on the vasodilatation, including nicardipine and labetalol that we have discussed. Also, like I told you before, there can be sudden rise in the intracranial pressure, and hence you will have to give anti-edema measures. What are the drugs used in anti-edema measures? They are your mannitol, which is an osmotic diuretic, which is going to bring out excessive edema. So, it is going to bring down the excessive edema, or you can give hypertonic saline or 3% NaCl. Okay. So, this is how you medically manage your raised ICP, right? Now, if the raised ICP is not going to come down, if it is not going to come down, as in the neurological status is continuing to deteriorate, patient is continuing to have anisocoria, or if the bleed is huge and the edema is huge, then you may have to do a hematoma evacuation. You may have to do a craniotomy to bring down the pressures. Okay. Many a times the patient may be on an anticoagulant. If it is an anticoagulant related bleed, then you may have to do a reversal of anticoagulants, right? So, an emergency management would be injection of fresh frozen plasma, which will help in the reversal of the anticoagulant. But if the patient is on specific anticoagulants and the antidotes are available, then the reversal agents or antidotes have to be used. So, the drug which is used for anticoagulant reversal in dabigatran is idarucizumab. Okay. And for apixaban and rivaroxaban, it is adnexet alpha. Okay, so anticoagulation reversal, if the patient is on anticoagulant, that also has to be considered. Finally, as last resort, if the bleeding is continuing, there is no improvement in the neurological status, you may have to do a hematoma evacuation. Okay, so this is about the various management options for a patient presenting with hemorrhagic stroke. Now, let us move on to the next type of stroke, which is your subarachnoid hemorrhage. Okay, so subarachnoid hemorrhage is also a very, very important part of your hemorrhagic strokes. So, if it is not a hypertensive bleed, if it is not an intracerebral hemorrhage, then you can consider your subarachnoid hemorrhages as well. So, subarachnoid hemorrhage can be mainly due to three reasons. So, we have traumatic, then we have aneurysmal, and it can be due to AV malformations. Traumatic, aneurysmal, and AV malformations. Okay, traumatic subarachnoid hemorrhage we will not discuss. We will discuss about aneurysmal subarachnoid hemorrhage. So, what is an aneurysm? Aneurysm basically means focal outpouchings. Focal outpouching within the vessels. Focal outpouching within the vessels. Okay. So, this happens mainly because there is degradation of the internal elastic lamina which is present within the vessel walls. Okay, so what happens is the media becomes very thin. The elastic lamina may also get degraded or it becomes thinned out, and hence you can have a focal outpouching like this. Okay, so if all the three layers are contained, this is what we call as a true aneurysm, and this has a neck and a body of the aneurysm. Now, since these are focal outpouchings and they are very thinned out, they have a high risk of bleeding. So, what are the sites of aneurysm? So, the most common site is at the bifurcation of the posterior cerebral arteries, which is your PCA. So, at the bifurcation of PCA, you have the most common aneurysms. The next most common would be at the bifurcation of the MCA, right? So, PCA aneurysms and MCA aneurysms are amongst the most common sites for your aneurysmal bleed. Apart from that, you can have aneurysms at where your PCOM joins your MCA, right? You can have aneurysms where the PCOM joins your MCA, and you can have anterior communicating artery aneurysms as well. So, these are amongst the most common sites for your aneurysm. What is the risk of rupture for an aneurysm? So, if the aneurysm is more than 1 centimeter in size, the risk of rupture per year is 0.5 to 1%. What are giant aneurysms? Aneurysms which are more than 2.5 centimeters in size are called as giant aneurysms, and these aneurysms have a risk of rupture for up to 6%. They have a risk of rupture amounting up to 6%. What are the clinical features? So, the first and the most important clinical feature is that there can be a headache, right? So, even in an unruptured aneurysm, you can have headache, mainly because as the aneurysm enlarges, it can compress on the pain sensitive structures in the brain, and this can cause headache, right? As the aneurysm enlarges, it can also cause compression of your surrounding cranial nerves. Surrounding cranial nerves can also be compressed. In a ruptured aneurysm, you can have a subarachnoid hemorrhage, and this headache is described as the worst headache of my life. Worst headache of my life is the description which is given to a aneurysmal rupture in a subarachnoid hemorrhage. Okay. Now, a sudden rupture can also result in a raised intracranial pressure, and this raised intracranial pressure can cause vomiting. It can cause vomiting. It can cause what type of vomiting? It is a projectile vomiting. It is a projectile vomiting. Then also you can have a sudden loss of consciousness, and this sudden loss of consciousness can be followed by recovery with neurological deficits. The recovery will have neurological deficits. If there is an ACOM aneurysm, right? So, this is here. If there is an ACOM aneurysm, what is the structure that is here? The structure that is here is your midbrain. So, there can be involvement of the midbrain in your ACOM aneurysms, which is your anterior communicating artery aneurysms. Okay. So, what does it result in? It results in a third cranial nerve palsy. So, you can have a third cranial nerve palsy in ACOM aneurysms. So, how will the eye be? Right? So, how will the eye be in an ACOM aneurysm? You have a down and out eye, because the third cranial nerve supplies all the extraocular muscles except the lateral rectus and the superior obliques. Lateral rectus is supplied by cranial nerve 6, superior oblique is supplied by cranial nerve 4, right? So, when the lateral rectus and superior oblique are going to act, the eye becomes abducted and depressed, right? Because all the other muscles are damaged, because the third cranial nerve is damaged. So, this is what we call as a down and out eye. Okay, so abducted and depressed, so this is a down and out eye. Okay, fine. And you will have pupillary involvement. You will have pupillary involvement. Where do you get a pupil sparing third cranial nerve palsy? You get it in diabetic neuropathy. Here you will have pupillary involvement, because whenever you see your third cranial nerve, The pupil fibers are more towards the exterior, so a damage from here will cause a pupillary involvement. Okay, clear? Right, apart from that, if the aneurysm is high or if there is bleeding into the midbrain, you can get other long tract signs as well. Fine? Okay. So these are about the symptoms of your subarachnoid hemorrhage. Now, how do you assess for your subarachnoid hemorrhage? There are some grading scales which have been proposed for your SAH. So the first is your Hunt and Hess grading system, and the other is your WFNS or your World Federation of Neurological Societies, Neurosurgical Society scale. So grade 1 is mild headache, normal mental status, no cranial nerve involvement. Grade 2 is severe headache, normal mental status, may have cranial nerve deficits. Grade 3 is somnolent and confused. Grade 4 is stupor. Grade 5 is coma with posturing. So this is about your Hunt and Hess scale, and the WFS scoring system takes into account your GCS. Based on the results, you can score them into different types. What are the delayed neurological manifestations? So when we speak about delayed neurological manifestations, especially in a patient with SAH, there are large number of delayed neurological manifestations. Always remember there is a risk of re-rupture, and this risk is around 30%, which is maximum at the end of 1 week. So anybody who is presenting with subarachnoid hemorrhage, be very careful and do an upfront treatment of the person. So if it requires a coiling, if it requires an interventional procedure, please go ahead upfront and you coil the aneurysm so that it does not re-bleed again. So the risk of re-bleeding is 30% and it's highest in the first week. The mortality goes up to 50% if there is a re-bleed. So be very careful. Then there can be hydrocephalus. Why? Because if there is a subarachnoid hemorrhage, this bleeding can track on to the ventricles. Okay, they can track on to the ventricles and it can result in intraventricular hemorrhage. So when the blood gets pooled into the ventricles, it can cause obstruction to CSF flow and result in hydrocephalus. Okay, so the bleeding can track on into the ventricles, cause intraventricular hemorrhage, obstruction to CSF flow and hydrocephalus. In these cases, you may have to put a shunt. You may have to put a temporary shunt, which is your ventriculoperitoneal shunt. We call it a VP shunt, so that it is a temporary measure to shunt out the CSF into the peritoneum, and this is a treatment for your hydrocephalus. Then we can have something called as DCI or delayed cerebral ischemia. Delayed cerebral ischemia also happens from 7 to 14 days. Okay, the predominant mechanism for your delayed cerebral ischemia is mainly due to vasospasm. So whenever there is an aneurysmal bleed or a subarachnoid hemorrhage, you can have a delayed vasospasm where the vessels go into constriction. When the vessels go into constriction, you can have an ischemia of the tissues as well, and this is your delayed cerebral ischemia. Right? So how do you diagnose it? So how is the patient going to present to you? So a subarachnoid hemorrhage patient who is improving, if he goes into a delayed cerebral ischemia, there can be worsening of the neurological deficits. He can become comatose or stuporous again, right? Or he can have worsening of the neurological deficits. So when you do an MRI with an MRA again, so you do an MRI with an MR angiogram, you can see that the vessels are in spasm. So this is how you diagnose your delayed cerebral ischemia. Okay, so you can understand that the vessels can go into spasm. Then you can have hyponatremia, right? So we had discussed this in our chapter on hyponatremia as well. So hyponatremia in subarachnoid hemorrhage can be due to two causes, which includes syndrome of inappropriate antidiuretic hormone or SIADH, or it can be due to cerebral salt wasting or CSW. Okay, so antidiuretic hormone basic function is that it is mainly responsible for the reabsorption of water, or it helps in antidiuresis volume expansion. So here, if the ADH is inappropriately high, there can be a dilutional hyponatremia. There is a dilutional hyponatremia, right? Okay, so this is your SIADH, which can happen secondary to SAH. Now this SIADH has to be differentiated from another condition, which is your cerebral salt wasting syndrome, where due to the SAH there is increased urinary sodium excretion. Okay. So how will you differentiate between your SIADH and cerebral salt wasting? Here only 2-3 points I will discuss. Mechanisms have been discussed in the hyponatremia class. So in your SIADH, the patient will be euvolemic and the treatment is fluid restriction. The treatment is fluid restriction. But in your cerebral salt wasting syndrome, the patient will be hypovolemic because when there is increased sodium excretion, there is increased water excretion as well. Patient will be hypovolemic or dehydrated, and the treatment for this is giving IV fluids. Okay. So this is one of the other delayed complications of SAH, which is hyponatremia secondary to either SIADH or cerebral salt wasting syndrome. Now, how do you diagnose your SAH? So on the CT brain you will find that there is a bleeding into it. Then what is the CSF finding that you can have in SAH? So what happens is that in your subarachnoid space you have CSF, right? So there will be lysis of the blood cells. There will be lysis of the blood cells. So whatever bleeding has happened, those blood cells can undergo lysis and there will be hemoglobin which is excluded out. So the hemoglobin that comes out gets converted into bilirubin. The hemoglobin that comes out gets converted into bilirubin and it imparts a yellow color to your CSF. It imparts a yellow color to your CSF and this is what we call as CSF xanthochromia. So you can have CSF xanthochromia or you can have fresh blood within your CSF. This is diagnostic of your subarachnoid hemorrhage. But always be very careful. Do not do a CSF purposely in the current era for the diagnosis of SAH because there is an increased risk of raised ICP, and in raised ICP you cannot do a CSF examination because it can precipitate a brainstem herniation. Fine. Then on the ECG, there can be characteristic deep T wave inversions, what we call as the cerebral T waves. Okay, there can be deep T wave inversions, what we call as the cerebral T waves in your ECG. Then you can do a CT angiography. In your CT angiography, you can find out where is the aneurysm, what is the size of the aneurysm, and when you do a CT angiography, you can also do an intervention and try to clip or coil the aneurysm. Okay, clear? So this is about the various laboratory features which you can find in your subarachnoid hemorrhage. Now let us move on to the management. Let us move on to the management of an SAH. So medical management will be the first line. For your raised ICP, I told you anti-edema measures. When it comes to the management of hyponatremia, we have just now discussed SIADH, you restrict the fluids. In cerebral salt wasting syndrome, you have to be liberal with the fluids. Then delayed vasospasm. Vasospasm can result in delayed cerebral ischemia, right? So the drugs that we use to prevent this vasospasm is your calcium channel blockers. Like nifedipine, which has vasodilatory properties. So we give calcium channel blockers with vasodilatory action like nifedipine to prevent your vasospasm. Now despite all of this, if there has been a vasospasm, then you can do something called as medically induced hypertension. So this is a very strange thing, medically induced hypertension. Now why is this done? Because you know that in subarachnoid hemorrhage, many a times there can be a hypertension related bleed as well. So in those cases, you have to bring down the blood pressure, right? But you can give medically induced hypertension to a certain extent. You maintain the blood pressure around 140 to 150 systolic. This is to ensure that the blood is flowing and there is no vasospasm. So this helps in prevention of vasospasm. Okay, you give IV fluids to make sure the patient is well hydrated and ensure that the blood supply, cerebral blood flow is maintained. So if this is maintained, there will be no vasospasm, right? Then interventionally, what happens? The last resort treatment for your vasospasm, if you have diagnosed and it is not improving on medical management, then interventionally you can go ahead and within the arteries, intra-arterial, you can give intra-arterial vasodilators, or mechanically you can dilate the vessel as well. So this is your last resort option treatment for your complication, which is your delayed cerebral ischemia. So the definitive management for a subarachnoid hemorrhage So as you can see here, what is this showing? This is your angiogram showing your aneurysm. Can you see the aneurysm clearly? Right? Then this is your CT, which is showing your bleed in the arachnoid spaces. This is your subarachnoid space. Right? So what do we do here? You can do interventional procedures, right? You put in a contrast, you localize the aneurysm as you can see here, and you can do a coiling. Okay, you do a coiling, right? So the definitive procedure includes a clipping, where you put a clip here, or you do a coiling, and the coil ensures that this aneurysm gets degraded on its own. The newer technique which is used, the newer technique after the development of interventional radiology, is a flow diverter. So a flow diverter means if the aneurysm is here, you put a diverter like this such that the blood does not go into the aneurysm and rather it continues its movement like this. So the aneurysm will not have any blood for a long time and it will involute on its own. So the newest technique which is used in the management of a subarachnoid hemorrhage is a flow diverter. Okay, clear. Okay, so I hope this is clear. So with this, we have understood what is your hemorrhagic strokes. So we come to the end of our session on hemorrhagic strokes. Thank you.